and then that goes up through Assurance Committee and Board. SHA reporting, again that's done quarterly for the national and the regional ones. We don't have to report our local ones up to SHA. And then we also have meetings internally where we agree validation and agree the payment level that's going to be made to that trust, if at all. An independent evaluation is ongoing at the moment. That will be reported to the Department of Health in 2012, and that again is going to use case studies. It's going to use analysis of the schemes that are ongoing at the moment, and also look at what's been happening to see if we can actually truly say that the sequence scheme is incentivising quality improvement across the NHS. So that's going to be available in 2012. And obviously from that time as well, our NHS landscape within England is going to change quite dramatically as well, and the NHS Commissioning Board will then take up responsibility for this programme and see how it works actually across the providers. So that's just a quick recap really on the sequence. It's quite detailed, but it's been quite interesting seeing, you know, how trusts have gone through this process and if they're actually meeting the reporting requirements and the deadlines, and they actually get payment for that. So it can get quite contentious really at the end of a quarter if they feel they've done all right and we feel that they haven't met that, you know, the required standard. So it's been quite an interesting process. But has anybody got any questions on sequins? I know it's probably new to you at the moment, but I know Dr. McCarthy, I think she alluded to it this morning, looking at commissioning for quality. And lastly, I thought I'd just give you a bit of information about our patient-reported outcome measures, or PROMs. Again, some background, potential uses, the process that we've got in place and some of the next steps. These are measures of patient's health status, but they're from a single point in time, but it's purely from the patient perspective. So we've got no say in this at all, and they're actually building on information that's coming purely from a patient. So since the 1st of April 2009, under the terms of the NHS Standard Contract for Acute Services, any provider who undertook any of the following 4 procedures had to report back into the PROMS process. So the ones at the moment are unilateral hip and knee replacements, there's varicose vein and there's groin hernia surgery. So they're the only 4 elective procedures on that scheme at the moment. The potential uses for the data then is, again, is supporting patients and GPs to make choices. We hear a lot about patients deciding and making choices, but to me, I think sometimes patients don't want really a choice. They want to be told which is a good hospital, which is a good consultant. But again, this is going to lead into that debate and give us extra information about the quality of services. Internally, it enables clinicians and managers to benchmark their performance because you can see all the data for all the different trusts across the country. So it allows them to benchmark their performance. It's informing us as Commissioner to judge the quality of care offered by providers. So if we see a dip, you know, you've got to question why they're doing that procedure and is it having an undue effect on that patient. Again, that leads into strengthening audit and research. So where we think that we've got a problem, we can do a clinical audit on that. And it's also going to meet CQC requirements and provide valuable information and evidence for NICE. So again, it's adding more and more into that evidence base where potentially there might be a lack of evidence. In terms of the process then, the patients complete one questionnaire, their preoperative assessment. That is then collected from them and it's sent to the DH contractor. So we have nothing else to do with that as a healthcare community. Once they've had their operation, they're sent to a preoperative questionnaire. And these are exactly the same things that they receive pre- and post-operatively. Again, it's all done by the DH contractor and we've got no control over that. It's 3 months from date of operation for groin hernia and varicose vein, and it's 6 months for the hip and knee. So analysis is used to determine the outcome of the operation as perceived by the patient in terms of its impact on their self-reported symptoms and functional status. It's also linked into our HES data, so they can start sort of building up a better picture of what's happening really. And in terms of the hip and knees, that's also linked to the National Joint Registry. And the figures at the moment are made available monthly. They are looking into maybe changing this, but we're not sure what's happening at the moment. And because this is a new programme, they are classed as experimental statistics. So in terms of what's collected for each patient then, There are 4 main things that are collected pre and post-operatively. We've got patient identifiable information, but this is only for linkage purposes only. It's not shared widely, so it's only to link the questionnaires up. We've got a generic measure of self-reported health status, so I don't know if you've heard of the EQ5D and EQ5D VAS, but these are 2 parts of the same questionnaire or same tool that's used. The EQ5D builds on these 5 dimensions of mobility, self-care, usual activities, pain, discomfort and anxiety and depression. And there are also 3 levels within that, so they can report whether they've got no problems, some problems or extreme problems. And this is purely from a patient perspective. The EQ5D VAS then gives us a scale that the patient can assess where they lie on a scale between 1 and 100. So again, it's purely from their perspective. And the beauty of using this tool is it allows us then to compare entirely different patient groups, because it doesn't matter what condition they've got, then they will be able to assess whereabouts they feel they lay within that overall score. We've then got a disease or condition-specific measure of self-reported health status. So in terms of the varicose vein, we've got the Aberdeen questionnaire, and for the hip and knees, we've got the Oxford questionnaire. So again, it's adding more information to support what the patients are saying, basically. For the groin hernia, there's no specific instrument to help us with this, so they use the FS36. So that's 36 questions, basically, that gives an overall. There's an overall score, but it just gives you an indication of the mental health and the physical status of the patient. And again, this is valuable because you can get a lot more detail about that condition, but we can't actually compare different patient groups or the conditions. They also ask them whether they've got additional comorbidities or existing conditions. So it starts giving you a picture. You're not just looking at one thing in isolation. You can start building up a better picture of that patient, along with the other things that they've got wrong with them. So the results are called experimental statistics, and they should be seen really as a starting point for making improvement. It's not seen as punitive and, they shouldn't get their hands slapped because they aren't participating. These first few years are all about trying to engage with providers and get them to report. So it's firstly to identify the reasons for overall performance, and then to identify what needs to be done in order to improve. But there are also maybe some extra considerations in these, in terms of a patient might not complete the post-operative questionnaire within the agreed timescale. So in effect, when they complete that second questionnaire, they might be feeling a lot better because it might be a longer time lag. From the returned questionnaires we've got at the moment, it's looking like the older age group patients are actually returning more questionnaires than possibly the younger patients are. And because we've got a choice in analysing all PROMS data or just looking at HES-linked records, they've both got benefits in terms of the information that you can start gleaning from this. And certainly I think it looks like it's been a positive step really in terms of engaging patients and getting them to report on from their perspective. And as a result of that, it looks like we'll be increasing the scope of the PROMS to include such things as asthma, diabetes, chronic kidney disease. But there are potential problems with that because we're not just looking at specific conditions like surgical procedures. These other conditions are going to cover a whole pathway, so potentially that might lead to some issues, that they've got to start thinking about more widely. Again, all of the information that we get on a monthly basis comes through the information centre, and that's where we can actually pull the data from. And once we get that information, then I just sort of tabulate our information for our specific providers across Sheffield. It's just really so we can start seeing if there are any trends initially. But obviously we work very much with our providers on that, and they've got access to the same data, so nobody's hiding anything. It's just so we can get a feel for how well they're participating and what the return rate is like. There's a King's Fund report, getting the most out of PROMS, so if this is something that you need to know more about, then that report is really useful. And I would suggest that, if you do need it, that's the website to go to. So that's a sort of quick run through on PROMS, but it just gives you an oversight really of what we're doing and how it links into quality and commissioning for quality as well, and getting the patient experience and feedback. So again, if you've got any questions about PROMS or anything, or if you can't think of anything but anything crops up in future, then they're my contact details.
just wonder what's been the experience in terms of people's uptake of this. I mean, how willing to get involved and get their opinions and so on.
I think it's worked quite well. Certainly in Sheffield, we can see a rise in the number of people who've been involved in that. But I think it's been running in conjunction with the POIS audit. So while all the data hasn't been put into the PROMS data source, if you like, it's been running in parallel with this other audit as well. So I think once that ceases and all the data is going into PROMS, then we're going to get a more realistic figure as well. But all trusts that should be participating are participating, so that's a really positive thing.
I don't have any really much experience with PROMS and patients' opinions. Is that information going to be widely available ultimately? Are patients going to be able to look up a database and say, this hospital seems to perform better than another? Because you have the potential of not comparing like with like.
Yeah.
And that can lead to a real problem. Also with the future of commissioning, especially in England, you have the potential for private providers to select cherry pick whatever group of patients who want to do much better and leave the NHS trusts with a sicker, slower recovery patient. And they will certainly not be like for like.
No.
And I think you must be very careful in the way the data is presented if you're not very likely.
Yeah, and like I said, when they report on this data, you can see exactly which organisations they are. So if they're if they're private providers or classed as, then we know that they cherry pick anyway, and that is ultimately happening. But I do agree with you, we have got to treat this with a lot of caution until we know more about it and how accurate it is, basically. But there are so many things that could potentially go wrong with it. It's like only certain patients are sending their post-operative questionnaires back, so that again could invalidate that. So there are so many things that they've got to think about. I'm sort of a bit mixed opinion about it, really. I think it's a brilliant way of getting the patient feedback and getting information from them related to their specific condition, because you can't look at things just in isolation. They might not just be having a hip replacement, it's everything else that goes along with that, and there's only the patient can actually tell you about that. But it's like I say, I think in terms of making the information more available, it will be available and it is available, but how patients choose to use that, either with the GP or on their own, it remains to be seen, really.
My experience might be that the private providers will use it to their advantage. The NHS providers to cherry pick even more of the patients than they wish.
Yeah.
And I don't think it actually benefits the NHS nor benefits the patients. That's my own perspective.
Yeah.
If you do publish data, that is not like for like.
Yeah. And I know there have been some problems, and they are looking into that to see, like again, how accurate the information is that's coming back from patients who are treated at different providers. So I think this is going to be interesting. We've certainly got our eye on it across Sheffield, so it's going to be interesting to see how that pans out, really.
Anyone else?
Alrighty.
That's it. Thank you very much, Beverley. There's been a lot of information there, and you see Beverley's details are there. We have them in the office as well, so if there's anything, get in touch with us and we will send that to you. I'd like to thank all the speakers that were here today. Martin, do you know what we forgot to do? We forgot to mention Martin got an MBE in the New Year's Honours list for services to the NHS. Am I right?
That's the one.
That's the one. So congratulations on that.